Good morning, everyone. We're going to give folks a few seconds to join. Thank you for joining today. See a good number, so let's go ahead and get started. Good morning, everyone, and thank you for joining us for this Assembly of Osteopathic Graduate Medical Educators, or AOGME webinar, entitled A Roadmap to Building and Implementing a Comprehensive State GME Strategy. My name is Alenta Long, Vice President of GME Initiatives here at ACOM. I'd like to go through a few housekeeping notes before I turn it over to our speakers today. This webinar will be recorded and available for viewing on the AOGME web pages shortly. Please feel free to submit questions throughout this presentation using the Q&A feature. And as there's time at the end of the presentation, our speakers will respond to your questions. If you experience technical issues, please use the chat feature at any time and notify us, and we will assist you. I'll now turn it over, just thanking our speakers, Emily Hawes and Lori Rodefeld from the UNC Sheps Center. They are our partners, as many of you know, on the ACOM UNC Sheps Center GME Development Fellowship. That's in its second year, and it's very successful. So I want to thank them for their partnership and their support of the osteopathic community and, of course, GME development. And they're also engaging with us in other initiatives to support GME overall, like this webinar. This is really a timely discussion on practical strategies to strengthen physician training pathways, improve workforce planning, and support sustainable GME growth. So we're very excited to have Lori and Emily joining us, and I will now turn it over to Emily to introduce herself and Lori as well. Thank you.
Thank you, Alenta and ACOM, as well as many of you for joining. It's fun to see familiar faces logged in. We're excited to spend the next hour with you. Hopefully, we'll talk for a portion and then really want to devote some time to answer your questions. We know many of you are already engaged in state GME work. And so we hope for those that are engaged that it gives you some practical tips of how to further that engagement. And then those that aren't involved, we hope that you consider getting involved because comms should be involved in this. So today we're going to go through a roadmap to building and implementing a comprehensive state GME strategy. My name is Emily Hawes, Director of the Sheps GME Center, and Lori Rodefeld's our Deputy Director. We are funded from various federal and state sources and want to acknowledge those and then also state that the views today do not necessarily represent their views. Next slide. Oh, I can advance. Wonderful. Thank you. Okay. So as you probably are familiar now, we want to give you a presentation in one slide. So there are physician workforce shortages across each of the states that you're in, and those shortages are even worse in rural and underserved areas, directly impacting access to care. And so that has led to growth of states getting involved from a strategy as well as programmatic effort. Many of your states are leveraging rural health transformation funding to address these shortages. And so what we want to do today is synthesize some of our research around rural health transformation and then really spend the majority of the time discussing a structured five-stage roadmap that provides you this coordinated path to build and scale GME. It involves technical assistance, data-driven planning, strong governance to launch, expand, and support programs all throughout your states and in partnership through your comms. Successful strategies are iterative, they're aligned with policy and funding and focused on outcomes like retention, specialty distribution, and ultimately access to care. We have a team at the Sheps Center that I do want to acknowledge on this slide that we're grateful for. So first, let's talk about rural health transformation funds and growing state GME efforts. Just from a show of hands, how many of you are in some way engaged with rural health transformation funds in your state? Okay, great. Please feel free. I see Cliff and Abigail as well. Feel free to jump in and kind of share your experience when we get to the state examples. This is a slide that we took directly from CMS's website that essentially gives the 5 strategic goals of the rural health transformation, which includes making rural America healthy again, sustainable access, workforce development, which is where we're focused today, innovative care, and tech innovation. One of our colleagues, Mark Holmes at Sheps, did an AI extraction, a very robust analysis that looked at kind of what are the states focused on, and his AI abstraction showed that workforce was consistently a theme across all of these applications. Interestingly, although workforce was big across RHTP, GME is not consistently. So states have included workforce on nurses, community health workers, as well as other non-physician workforce, but there are many physician initiatives, including both GME as well as recruitment and retention efforts. But as you may know, and we actually have found this out from increasingly as we're working with different states, is that many of all of us are unsure still what is going on with rural health transformation. And so I want to pause here and say only a few of you raised your hand, and that is actually a consistent theme. It still feels like there's a lot of ambiguity around this. And so you are not alone. We are in that same boat with you. So a couple of examples we wanted to share today. In our state, one of the specific goals that they put in Initiative 4 was to expand simulation labs and interprofessional training. And I think that red is supposed to be over launch new rural residencies and fellowships. Sorry about that. And so there is this effort across all of our different hubs to grow GME programs. In Washington, they're expanding family medicine residencies through the WWAMI Family Medicine Network. They have specifically mentioned 4 more clinical residencies by 2030. In Maine, they're going to use funding to expand through their consortium to expand residencies. Iowa is pairing state actions with a supplemental enhanced payment for GME in acute hospitals. North Dakota, in their application, wrote about creating new physician residency training slots, including tribal specific residencies. And then Minnesota is actually going to use that funding to create a state technical assistance center. And I think actually other states are considering or engaging in that type of effort. So in summary, the RHTP funding represents this generational, time-limited opportunity to transform rural healthcare. Most, if not all states are doing something in the workforce space. But that being said, GME is less of a common strategy. I think that where I'd like to leave it is that, it seems like there may be flexibility in the future, even if you aren't necessarily engaged in GME right now. There may be flexibility in the future to kind of incorporate GME as part of this effort, but it remains to be seen. And with that, we'll turn it over to Lori to talk about our roadmap that was just published in Milbank.
Great. Thank you so much, Emily. And, thank you, Alenta and the team for inviting us. This roadmap to a comprehensive GME strategy is something that we've been working on for almost 2 years. This really, as we've increasingly been working with states, talking with states, and really helping them explore what strategies are most effective to really impact physician workforce, this roadmap became kind of a priority. And if you know us at Rural GME or THC GME, we love our roadmaps. So, of course, we had to create one on how to create a state GME strategy. And I think that this will hopefully be helpful for all of you, because I think that as we look at the comms, we look at the osteopathic mission, you all are great partners. You're all committed to growing workforce in your communities. And again, whether it's through RHT or other state appropriations or state funding mechanisms or just, data infrastructure, there's a lot of ways that you all can get involved with a comprehensive strategy. So we're glad to have you on the call. If you'd like to take a look, our Milbank brief, like Emily said, was just published. You can read the full brief. We'll be going through some of the highlights from the Milbank brief. I also want to note that in probably about 2 weeks, we actually have in its final iteration a case example supplement that will actually have 3 detailed cases from Wisconsin, from Missouri, and from North Carolina. And many of the examples that we're going to share with you are kind of a preview of some of those things that will be shared. And additional information. So again, we really wanted to kind of update this presentation for this community to kind of show you some of the, tangible artifacts or outcomes or examples that really kind of connect to our roadmap. And that's kind of the idea of this case study piece. But again, we'll go through the roadmap. We'll talk about each of the 5 stages and help you understand how things could fit in your particular state. I think that the Rural Health Transformation Fund is perfect timing. We started this 2 years ago. We didn't know Rural Health Transformation Fund would be a thing, that it would, connect so well to this, but we were really thrilled to kind of have that alignment around timing. So again, why a comprehensive roadmap? And I think that, as Emily and I and our team continue to work with different states, we're really seeing that things are not done in a coordinated manner among stakeholders, right? You might have the large academic medical center getting a lot of state funding. That's great. But again, what about the community-based hospitals? What about the health centers? What about your comm? Like, how are you connected into what's happening in your state? And we know that that fragmented planning can slow progress. Just one example, we've been working really closely with Arkansas. And again, just in our analysis found that actually they're only training 5 general surgery residents per year. So they're graduating 5 surgeons each year. And again, without paying attention to this emerging issue, they've kind of created a workforce crisis by not really addressing comprehensively on a state level, what are the physician workforce specialties that we need? Where do we need them? So again, we're doing a lot of work to really, kind of move from fragmented planning to coordinated planning. And we also know that this lack of structure statewide can create inefficiency and really miss opportunities. And states are continuously pursuing these GME initiatives independently, which again results in fragmented and siloed efforts. Again, I think everyone throughout the state usually has the best of intentions, right? Whether that's your comm or whether that's the AMC, they're all doing their best. But when people don't come together and have discussions around what's needed or where GME needs to grow, then it misses that opportunity to really think about things in a different way. So our roadmap has 5 different stages. We'll go through each of these. Really the initial stage, and again, if your state isn't doing a lot with GME development, exploration may be where you're starting, but there's pieces of exploration that you can go back to. So again, while it's a 5-stage model, it's really designed to be iterative, and there may be pieces that you've already done. But again, this is just an opportunity to look at all of the different, kind of pieces of what a comprehensive state strategy includes. So again, we'll go through each of these, but it really ranges from exploration to really developing and designing the strategy, incorporating TA or technical assistance, and then also looking at how you can optimize your strategy. And again, this is designed to be flexible, not a rigid framework by any stretch of the imagination. So this is our roadmap. I encourage you to take a look at this. It kind of goes through those different stages from exploration to strategy development, strategy design, technical assistance, and optimization. And again, I think, if you look at kind of the key themes that we have throughout the roadmap, it's about bringing people together, coordinating efforts, getting good data, understanding what your strategy and your plan is, and then executing and really doing that, kind of check in. Is this having the impact that we want? And do we need to go back and refine some of these, efforts that we've implemented? So really it's looking at, how do you do this comprehensively? How do you design the strategy? And how do you ensure it's built on a strong foundation, good data, and good support? So again, we'll go through each of these stages one by one. So in the first stage, we have GME exploration, and this is really where you're going to do a lot of, kind of determining what's your baseline. What specialties do you have? What shortages are you facing? Doing a GME inventory, kind of, assessing, okay, where's all the training happening? Where do we have GME naive hospitals that could become training sites? Do we have health centers that are interested in, becoming involved? What's the funding landscape? Is there federal funding you could take advantage of? Is there state funding? Are you maximizing your Medicaid reimbursement? Is there private funding available? Really looking at all of the different options that you have around funding. And then importantly, stakeholder engagement is key. Great state strategies are built on broad stakeholder engagement. This can't be the project of one specialty or one, academic medical center. This has to be truly a partnership across the state to really review data and then set those priorities. And then I think early on, you want to have some policymaker education, really looking at data-driven workforce insights, but then also just, some of the basic things that need to be addressed early on. Legislators may not know what GME is. They may not, and don't use, Heidi Miller from Missouri always says, don't use the acronym GME. Say graduate medical education. Tell them that it's a post-medical school training program. Tell them what it is and tell them that it's required, and how it fits into the physician workforce pipeline. I think the other thing, that I've really seen as we've worked with different states is the need to really even explain what a sponsoring institution is. I've actually had a conversation with one state that they thought that large academic medical center in their state was the only place where residency training was occurring. They didn't know about the health centers, the rural hospitals, the osteopathic medical schools that sponsor residency training. And so again, just educating, if you are a sponsoring institution, how many residents you're supporting, which programs, where they're located, because legislators aren't familiar with GME. It's really complicated. So any way that you can simplify this can be super helpful. So we're going to give you a few examples of kind of that stage one work. And this is actually something that we did with Missouri to kind of highlight, where residency training is occurring in the state, and then also importantly, where it's not occurring. So as you see, this is just a training site analysis with every single training site. And most of the training is occurring in Kansas City and in St. Louis, and there's pockets of some other training. But again, there's a huge opportunity to grow as you look at the entire state. And interestingly, we've been able to overlay this with some HIPSAs. And, if you look outside of St. Louis and Kansas City, all of the HIPSAs are in those other counties. So again, there's a really great opportunity to grow training and expand training. And, I'll be sharing other examples from Missouri, but I think that this just really demonstrates, and it's a powerful graphic that you can share to legislators when they, again, you're having conversations around sponsoring institutions and training sites and where training is happening, to be able to visualize this. And, even if they're in a district maybe where, there's no training happening, to say, look, you could have training. We know that there's hospitals that could host residents, to help them see how funding could hopefully help make an impact. And now I'm going to have Emily share some really great maps from North Carolina, which I think even, take this a step further.
Yeah, I think one of the questions we get is, where do we get started, right? And I think if you can't, a good helpful place that we have done, because we're years behind places like Wisconsin, is first just map out where training is. We know that residents tend to practice within 100 miles of where they train. So the distribution of training is actually a good proxy to determine how to get the distribution of physicians more equitable. And so one of the first things we did in North Carolina is map out the physician supply with the workforce. We're fortunate to have a long infrastructure of data that from licensing boards that helped us to do this. And so you can see here, there's been this concentrated effort across really the past 20 years through leaders like Mountain Area Health Education, Campbell, UNC, ECU, other kind of entities that have worked on really just expanding training across our state. And so for family medicine, one of the first things we noticed is that there's actually a lot of green. Green reflects higher supply of that physician. And so we have a higher supply of family medicine physicians in places where there's been this concentrated effort to grow GME training sites. Contrasted, we see for surgery, there's not a significant amount of surgery distribution sites, of training sites. And so we have, 25 counties in North Carolina that have no general surgeon. We have no rural surgery programs. And so that was one of the things that just stood out as we started planning of, okay, we've got to figure out ways to expand rural surgery training. We certainly need primary care. We have shortages across all these different specialties, but particularly for our hospitals, and a lot of the data that we've looked at for hospital capacity, where we've been really concentrating our effort, is expanding surgery. I'll also show you another map. You can see here we have really a dearth of pediatric training in our state, and also we have 19 counties in North Carolina that have no pediatrician. So using that data can be a helpful first step.
Yes, no, thank you, Emily. And again, that just kind of shows you what stage one can look like. And again, I think looking at the data, looking at training, looking at where training is happening is the perfect foundation to then move into strategy development. And again, I think when we look at stage two, it's really about bringing stakeholders together to validate specialties, regions, and training priorities, really looking at that capacity, but then also potential for growth. Where could training, where could training be built? Looking at funding, again, you may be underutilizing Medicaid, GME. You may have an opportunity to get some additional state appropriations. Some states have used philanthropy or even non-traditional sources. One example I like to highlight is Missouri has used opioid settlement funds to help support GME, and then they have integrated addiction training into all of the new programs that have launched. But similarly, states like Oklahoma have a tobacco tax, which helps support GME. So again, there's some other creative structures that can be considered as you're looking at GME. So again, don't be afraid to think outside the box. There's lots of different ways that this can be done. So again, I think another thing, as you're looking at stage two and designing a strategy is really to develop a governance structure. This is how you can get the broad stakeholder input. I'll be sharing an example from Missouri. They have probably one of the best governance structures that I've seen. They have an advisory committee that really just brings together broad stakeholders to really, kind of address what are the GME needs of the state, what are the workforce needs, what's the data that we need, and then how do we collectively work together to grow. And again, what you want to do in stage two is also aligning your strategy with policy agendas and legislative opportunities. Pay attention to your state's legislative cycle. You could do all this great work, but if you miss the window of opportunity to get something included in a state budget, you could be waiting 2 years before you see funding come your way. So you want to pay attention to those timelines and be ready to go and really, try to get ahead of it at least probably 6 to 12 months. But, you don't want to have this wonderful strategy, shared with legislators right after they settled the, biannual budget, for example. And then you want to start to define resources and timelines necessary for implementation. So again, all of this, needs to have a strategy. It needs to have a timeline, so that you can implement and execute an effective plan. So again, I shared with you Missouri's great advisory committee structure. What's really unique about what they've done is they've included broad specialty representation. Their hospital association has been a key partner. Their primary care association. They have a rural health association that also helps. And then I think one thing that I really appreciate about what Missouri has done is they've really involved Medicaid from the beginning. Their Medicaid office is very supportive of GME. They are a key partner and a key ally in this work. And it was a really good strategic move to have them at the table. And just some of the discussions we've had, they've been really open to, additional ways to support training throughout the state. And actually, since they've gotten involved in this advisory committee, they actually went from having just DGME payments to hospitals training residents. Now they've added INE payments. So again, because they've learned about GME, because they appreciate GME, and because they see the value in what it's doing to produce the workforce that the state needs, they've actually increased funding for the state. So again, thinking about, with this advisory structure, how can you leverage partnerships and relationships? They also have rotating members. So these are folks that rotate on and off of the advisory committee, and that includes two specialty association representation. They are blessed to have a number of medical schools, so they can't have all of the medical schools at the table at the same time. So they do rotate members from the medical schools, and they do try to include allopathic and osteopathic concurrently. So it's not just allopathic or just osteopathic at one particular point in time. They also have two sponsoring institutions, two accredited primary care programs that have been in place for less, or one that's been in place for less than 4 years. So again, they want that new program perspective at the table to share the struggles and, just any of the obstacles or barriers that have come up. And then they want a more established program as well. So again, it's been a really great advisory committee structure. They meet 4 times a year. And I want to give credit to AT Still, which is the Technical Assistance Center that is really, leading and, corralling all of these key stakeholders together for their advisory committee. And again, they're having great discussions about the needs in their particular state. I also want to highlight the capacity analysis. This is something that we did early on in working with Missouri, and it was really looking at, okay, of the hospitals that are not currently training residents, what's their GME capacity? And, and again, it's just a simple, kind of 35% of the average daily census calculation. But then you also want to know what the hospital type is, because any of you who've done GME development know hospital type can drive funding, and that can have a huge impact on what can be developed. But you want to know kind of what your local landscape is, and then what is the total capacity for growth. And you want to know that for your own state, because legislators want to know, well, how many residency positions could we create? And when you look at Missouri, they have potential, and this is if everything worked out perfectly. Every single hospital was interested to create 1,000 new positions. So they actually set that as their goal. They want to create 1,000 new positions in their state because they know that there's capacity. And again, a lot of really great work is being done, and there is potential to grow, and they already have started some really great work growing new programs. In stage three, this is where you get into the strategy design, prioritizing the needs, and really determining what you want to include in your plan. You're going to want to define what specialties and programs you want to create, or what specialties or programs you want to expand, how that's going to be funded, what types of funding mechanisms you may want to include. A lot of states will do feasibility, program development, expansion, sustainability, rural rotations. Those are just some examples. We've even seen some more innovative approaches recently, like in North Carolina, which we'll talk about in a little bit. And then we also want, at this time to really kind of figure out how much is this going to cost, because any legislator or policymaker is going to want to know, what's the total ask here to develop this state strategy. At this point, you'd want to designate a TA center entity. Sometimes that's just assigned because there's an obvious, organization with some expertise. Like in my state of Wisconsin, the Rural Wisconsin Health Cooperative volunteered to create WCR GME, and we serve as a technical assistance center entity. Other states like Missouri actually had a competitive RFP process. They had numerous applicants who came forward who were interested in running the TA center. Again, like I said, they selected AT Still. And then at this point, you also want to start to establish outcome measures and build a statewide tracking system. Because again, the key thing that you'll want to focus on with a statewide strategy is what's the impact? What's happening with graduates? Are they staying in the state? Are they leaving the state? How many positions have been created? Because that data will help inform future strategy and also hopefully demonstrate success. So I'm going to talk a little bit about Wisconsin, and this is going back to 2004. We actually, kind of started this work 22 years ago. And what we set out to do with this was there was a GME task force that was established. And because of this work, they came together and created this great report. It was a great tool to hand out to policymakers. It was called 100 New Physicians a Year. And that was kind of the goal, was we want to create 100 new physicians every year in the state to meet the projected workforce shortages that we're facing. And again, with some state funding, we moved past rural rotations to intentional training pathways, creating new GME, making sure that state investment supported the rural workforce needs that the state had. And then, the other thing that was really important was making sure that the risk was lower for programs to start and grow GME. And that was done through technical assistance, but also through funding, right? A hospital, is maybe interested in GME development, but if there's no funds to make that happen, it's going to be a big uphill battle to get the program off the ground. So back in 2013, there was funding allocated to the state, $750,000 for a 3-year startup grant with required rural training that was included. That was actually a required 2-month rural training experience. Many of the programs have far greater than 2 months of rural training. And then the other kind of key initiative that was established at that time was the expansion program, which was funded at $75,000 per position. I'll give you kind of a spoiler of our long-term impact. We've increased since then, just in the last legislative session in 2023. The funding for startup has been increased to $1 million, and it's actually a 5-year development period. The required role training has maintained itself. And then on the expansion side, that funding has increased to $150,000 per position. And it's because we've had good data and good support from the legislature. But again, this was the initial strategy that was developed from the task force, was to kind of focus on program development, program expansion to grow the workforce that Wisconsin needed. I'm going to let Emily talk a little bit about, I think North Carolina has a really great grant program that's been developed through the North Carolina Rural Medical Training Fund. And there's a number of different grants that have been established to help support and grow GME in North Carolina.
So through this work, we were fortunate to have both non-recurring and reoccurring dollars from our state assembly. And so we mirrored what we've seen in Wisconsin and other states, as well as RRPD, the development grant, over kind of a 3-year time period that is not renewable, right? It's a one-time only grant. We also have expansion grants. And so those are for existing programs that are really capped and can't really grow with Medicare GME. So that's an ability for them to get state recurring dollars that otherwise they wouldn't be able to increase their complement or number of trainees. The other kind of grant category is sustainability grants. So for example, we have a couple of existing programs that are in health centers or they're in Soul community hospitals, and there really is just this gap in funding that they're facing for sustainability. And so this is a way to really make them whole with recurring dollars. All of these things include tracking of graduates and reporting, annual reporting to the legislature to, continue their funding. And then the last category was something we created to really kind of give the opportunity to let rural communities to innovate and think about interprofessional training and other kind of disciplines that are part of teams and that increase access to care. And so we were able to give funding for starting a dental residency, a pharmacy residency, some different kind of interprofessional teams in rural communities. Also, there's a lot of funding that has gone out for fellowships, which we know are really important for new grads and helping with those retention measures. So there's an existing kind of Western North Carolina fellowship that is going to be expanded statewide through this effort.
No, it's great. It's really neat to see what's been created in North Carolina, and I love that innovation fund. We've been talking a lot about technical assistance, and we often get asked, well, what is TA? And honestly, we see a wide variation among states in what technical assistance centers offer, what they provide. I would say that when we look at, RRPD, for example, I would say that they're the gold standard when you look at technical assistance and how programs are supported through the development journey. But technical assistance can exist in a number of different ways. And really, Shelby Rimler-Cohen from our team did a great job of defining what TA is. And I'm not going to read this all to you, but really, TA is designed to support programs through partnerships and supporting organizations in their design, launch, and sustainability. So the programs are responsive to the needs of the community, really looking at what programs need, how they can be supported. And I think the important part of TA that sometimes gets overlooked is the importance of peer learning and coming together, whether that's an in-person meeting where folks, connect with each other, program directors meet each other face to face. And sometimes specialties may get together. But there is, I think, value in, I'll just give you an example. We had an event last year in Wisconsin, and I had a neurology program director. He wants to create a rural track, and he was so excited that he found his people. He was like, "Wow, I'm getting a lot of pushback from my colleagues that we shouldn't create this neurology program because they traditionally are housed at large academic medical centers, and I'm finally seeing that we can do this training, we can provide rural training, and we can create a community-based program." But again, sometimes it's bringing people together to show them what's possible, but also that they're not alone in their struggles or their challenges. Developing a new program, sustaining an existing program is hard work, and creating that community is just invaluable as programs launch and as they're sustained. And again, I think TA can help serve that role, but they can also, gather the data. They can also answer the questions, and most importantly, help support grantees to show them that, while this work is complex and hard, that they can do it and they're not alone in this journey. So again, TA, I think, is a key part of a well-run state strategy. And there's different things that TA can help support. Of course, program startup, that's something that's absolutely key for a TA center to be providing, is really helping, first of all, sites that haven't even applied for funding to see what's feasible, what's a timeline that could be developed, what readiness evaluations are needed, and then to really help support through the planning process, accreditation, and financial modeling. One thing that I do a lot of is scenario planning, looking at potential partners. If you're a rural track or a health center, how can you make this program happen through different options and, just different approaches. And then I think the other thing, is providing that education for stakeholders through that program startup phase. Relationships are key in this work, and to be able to develop a broad network of support to make GME new program startup happen is key. GME expansion is another area that TA can help support, really looking at what are those successful programs that are ready to grow. In Wisconsin, we've grown a lot of new rural residency programs, and we actually have a number that want to expand. So we're helping them because they've had good success, find ways to expand. But then I think what's also neat is we've seen specialties that may not be able to create a rural track. For example, the OB-GYN program at UW several years ago, before the Consolidated Appropriations Act, they wanted to create a rural track. There just wasn't a funding pathway for them. So we were able to get them some expansion funding and, some sustainability in adding one additional resident per year. And we've seen that that model actually follow. Another health system has created an expansion of their OB program, and they're doing 2 months of rural training. The other aforementioned program, they do closer to 18 months. But again, we're excited to see programs grow, programs expand, and really help meet the workforce needs in our state. And then with expansion, the other kind of key component of that is really looking at which programs are poised to grow, which programs could support additional trainees. Are there hospitals that are operating under their GME potential? And, could they expand, say, their internal medicine program or their family medicine program or their surgery program, and really look at how you grow GME when you are constrained by CMS caps. And then again, I've talked a little bit about this already, but good TA provides a lot of support for curriculum accreditation, barriers, and sustainability. Just one example is just this past week we did a mock site visit with a program that's going to be going through an ACGME site visit next month to really just get them prepared, feeling comfortable and confident with an ACGME site visit. I've talked about peer learning networks already. And then I think the other, important aspect of a TA center is to maintain the data collection systems to really, kind of watch what happened with the match. Is there an opportunity to help support recruitment of programs or support like a recruitment fair to let medical students know about the great training that's happening in the state? And then what's happening with the graduates of the program? Are they staying? And if they aren't staying, why? One thing that we did in Wisconsin is a few years back, we partnered with our Wisconsin Academy of Family Physicians, and we did a graduate placement survey. We actually asked all of the graduates from all of the rural programs, whether they were family medicine or not, did they stay? If they didn't stay, where did they go? And what were the variables in their decision not to stay in the state? So again, it was a really, I think, insightful, discussion and analysis that we were able to, kind of partner with another organization on. But again, I think, with TA, it's also looking at what data do you have, what data do you need, and how do you help support programs so that they're successful in the long run. I'm going to let Emily talk a little bit about some of the TA services that North Carolina GME provides. But again, it's really been great to work with the team to create some of these awesome services.
Well, Lori highlighted it well, and I will just augment what she said by saying it really is for both those existing programs. What are those supports so that they can sustain and be healthy long term? And it's building capacity for other sites that maybe haven't been engaged. We have a feasibility assessment that we've created that's available on our website that is a helpful tool for that, and helping those that are developing a full-blown GME program. So it's really helping all of those potential facilities and partners kind of see their role in it. An annual convening, faculty development tools and resources, and a lot of financing support and accreditation. We also just did an accreditation site visit or mock site visit this week in North Carolina. And then really helping convene, we're going to do a rural residency summit this year that really helps with marketing and recruitment as well.
Yeah, so this is not designed to be an all-inclusive list, but I think it's a really great starting point for a state TA center to think about, how you can support programs, both those that are interested in creating GME, those that maybe have a grant to help fund and support GME development, or those that have already launched and they want to kind of connect in and be part of that bigger community. So again, TA is really key to bringing people together, but also creating that community. I'm going to talk a little bit about the peer networking. Again, I talked about this a little bit already. But we do an annual faculty development conference, and faculty development is important for any program. But it's really neat to be able to bring together multi-specialty physicians and their teams to really look at, how do we, work together to create this community. And again, the faculty development conference is just one event that we do. But I think last year we had 60 rural physicians come together from OB, from surgery, from psychiatry, from family medicine, internal medicine, med peds. They all came together and we had not only some great learning, but some great connections. And it was really neat to see just resident participation, student participation as well. We really want to, kind of create this community, and bringing people together in person is absolutely key. And I think that, these are things that TA centers can do to really foster relationship building so people don't feel like they're alone in this work. If you're a rural program director, you could be the only one doing that work within your whole hospital or health system and not feeling like you're alone. Even if you have a great sponsoring institution, you may be 3 hours away from that sponsoring institution. So it is, easy to feel isolated or alone. So the idea of bringing people together is really important. And then the last stage is optimization. So this is really, you've done the work, you've got a strategy, you've got a plan, you've got a technical assistance center supporting, what do you do next? And, the work is not done. Just like if you launch a new GME program, there's a lot of work that happens after that program launches. And it's no different with the state strategy. I think that, maintaining that ongoing outreach to programs is absolutely key. That was one of the reasons why we increased the expansion grant funding amount, is we actually did site visits with a number of the programs and heard from them that they were concerned about the funding amount. It wasn't sustainable. They couldn't sustain their programs. They were operating at a financial loss. And hearing that feedback, we were able to collectively come up with a plan and an ask of policymakers to increase that funding amount. You also want to, evaluate offerings for technical assistance. We've done things that have worked really well, and then over time, maybe that interest fades, and we have to kind of re-strategize what's going to work better. So again, it's always looking at what's working, how can it be improved, how can it be refined. And then again, always looking at the data to help guide future investments. And, again, what data do you need? What data can you get? There's new data coming out, almost every month that you can capture to really assess what's working and what's not. And then again, sharing those results broadly with stakeholders to inform policy and future funding decisions. I'm going to share, this is our training site map from Wisconsin. And again, we showed the maps for North Carolina. We were not as fancy back in 2012 with our maps. This was just a really simple map of our initial partners, folks that were interested in GME or had GME programs. So again, you can see there were about 13 sites. And then now we are right around, we're actually going to be updating the map even further, but we're probably closer to like 40 to 50 rural training sites and programs across the state. So we've been able to, kind of demonstrate through this map, just kind of where is training happening and where has it grown. And then the other thing that we've done is really tracked, how many positions have been created. And actually, this is a little bit higher now because we've just awarded some new grants and have gotten a few new programs accredited. So I think this shows around 300 new positions created. It's actually closer to 320 now since this was created. But again, we're always tracking new program accreditation. We're tracking the number of positions using the ACGME data whenever possible, but then also talking with programs. We'll find out from some programs that they're interested in expansion or they're planning to grow even further. So again, connecting with programs, talking to them directly, but then also tracking those publicly available data sources. So again, why this framework and why focus on state level application? Again, this just really moves from fragmented ad hoc efforts to a coordinated plan that brings everyone together. It helps you build GME. It supports recruitment and retention. It establishes TA infrastructure that can enable long-term viability of programs. It's a lot of work to develop new GME programs, so providing TA to make sure that they get off on the right foot is absolutely key. It's a missed opportunity if a hospital is given a grant and they don't know how to launch a GME program. We want to help support them. And then, again, the big focus on continuous improvement is also very critical as you look at outcomes tracking and refining the plan over time. And again, when we look at state level implementation considerations, some of the things that we've seen in different states is, you really need to have a lead entity or a key partner that's going to help champion this process through. I think of, Missouri and Heidi Miller and what a key role she's played with DHSS and really kind of getting that team on board to embrace GME. If that team had not been as strongly positioned to grow and to influence. I don't know that their plan would have looked as great as it does now. And I think that the other, kind of key implementation consideration is TA is essential to build capacity. Someone needs to own the coordination and own the plan for GME in the state. And then the other thing is to really establish your baseline GME so you can track the outcomes, track the new programs, track the new positions, track the outcomes. And then again, key consideration is the budget cycle and the timing of, when you're going to need to engage with policymakers. And then just want to highlight how you can use our roadmap. And this is something that has actually come up like 2 times in the past week. We've had folks reaching out to us asking really detailed information about state plan amendments. And this is all in the roadmap. So you don't need to email Emily or I. We will happily respond if you email us. But we also want to empower you to go to the roadmap and look at Table 1. Table 1 is the hard work of Raquel Davis, one of our team members, who actually spent almost a year really just tracking all of the different states. What specialties are they supporting? Do they have rural or health center provisions? What does their state grant look like? Do they have a state plan amendment? And this really empowers you to go find a state plan amendment and to really understand what's going on in your own state, but also what's happening in your border states. It's really great to use, kind of some friendly competition as you're working on this in North Carolina. If you mention Virginia or South Carolina, you're going to get a lot more interest from policymakers than if you say, oh, well, California is doing this, right? I think that you want to look at what are your border states, your competitors doing, and do that comparison and analysis. It's also a great opportunity to say, hey, is there a border state doing technical assistance? Is there technical assistance in your state? Maybe technical assistance could grow or expand further. So again, look at some of those examples that are in there. And I think most importantly, look at those direct links. You have all the links to various grants, funding opportunities, and state plan amendments. You don't have to reinvent the wheel. I know when we were in Missouri working with them, we actually did a deep dive for planning and development grants. We found like 6 different examples of other state planning and development grants, and we didn't have this great tool. So it was a lot of, manual searching, a lot of conversations and asking other states questions. And now all of that information is right in Table 1 for you to take advantage of. So I encourage you to use this resource. It's designed to help all of you. So kind of key takeaways, states can benefit from coordinated structured strategy. The framework provides actionable guidance. They can be adaptable, iterative, and evidence-based. And again, TA and data systems are key in developing a successful strategy.
I'll chime in and share that our annual meeting is one of the most important services we provide. It's open to anyone interested in expanding GME. We are going to have quite a bit focused on state efforts this year, and so I encourage you to consider applying, or not applying, registering. And then finally, this is our contact information, and you can see here that it all kind of rolls up to Sheps GME. We are launching a new state GME service very soon. And with that, we'll pause and answer any questions, or if others want to chime in with something that's been helpful for them and kind of really engaging at the state level, we'd love to hear your feedback and guidance for others too. Oh, the first link. Which one? The annual meeting one? I may have pulled the wrong slide. Yes, we'll pull it back up. Hey, Lori, can you put up the annual meeting one again, and then let's make sure. Hey, Carrie, is that the one that wasn't working? Oh, the recording link for the webinar? Any comments, questions for us? Good. I'm so glad, Randy.
Yeah, we would love to have as many of you join us at the annual meeting as possible. I think, if you're just interested in learning about GME development, if you're interested in GME finance, if you're interested in just networking with a great community, the annual meeting is just a great place to do that. Our team has been really engaged even with ACGME. We'll have hours with different, executive directors. So if you want to meet with them and ask questions, that's a really great way to connect with just kind of different key partners and stakeholders. But again, just really great learning. And we will have, I think, at least, a couple of sessions really specific to state GME. So we'd love to have you there. And we're excited that Carrie and Dr. Hiles will be there presenting on some of the work of Missouri. Again, I love the examples from Missouri because it's really just a wonderful example of, kind of broad stakeholder engagement, right? The fact that all of the osteopathic and allopathic medical schools are coming together to really grow physician workforce is pretty exciting. And again, I think if every state could be like Missouri, we would be a lot better off. So that's an interesting question, Jonathan. I want to mention this, the lick into the residency curriculum. I know, one thing that I'm a huge fan of, and we've done this in Wisconsin, and I know Missouri has some examples of this, as well as North Carolina, kind of these accelerated pathways. And in Wisconsin, we've gotten NRMP exceptions for a number of different programs that allow those medical students to directly track into programs, and they're primarily family medicine. We've seen a lot of really good success in NRMP exceptions. And again, it's something that if anybody wants to talk about the NRMP exception or wants to see an example of the NRMP exception application, one that's been accepted and replicated and accepted by other entities, I'd be happy to share that. I'll put my email in the chat and you can email me directly if you'd like to do that.
And
Lori, I think, yeah,
they can't see the question. Sorry. Yes. So should we repeat that question? This is basically
yes.
saying, are the family medicine new programs in our state are nervous about the match, and unfortunately, their medical school has not supported the accelerated pathways, and so that was Lori answering that question. Do you have further follow-up on that type of question? We didn't notice the host versus panelist question. Sorry about that.
Yeah, we just thought it was a chat. But I would say with the NRMP exception, I mean, I've actually had some discussions with one particular state that was looking at creating some funding specifically for that. Again, I don't know that it will get approved by CMS, but it was at least asked, like, what could we do to help support like our primary care residency programs that are struggling with recruitment? And could we fund, like, I don't know, $50,000 to explore a new partnership that would, kind of build this path from UME to GME? And I want to say even in North Carolina, we've explored like some funding under that innovation category for the same thing. So again, I think, there could be some potential with rural health transformation to build out these partnerships and really, just again, that if they go to med school in your state, they do residency in your state, there's probably like an 80+% likelihood that they'll remain in your state post training. So again, that's a reason to invest in these relationships.
Still have a few minutes. Are there any last minute questions? See a lot of thank yous.
Yeah, or any, feel free to even just chime in with maybe some, I don't know, challenges or things that you all have faced in your own state. We would love to, just hopefully empathize with you, if not maybe offer a solution, because we know that, as Emily noted, there's a lot that we don't know yet with Rural Health Transformation Fund. And, even in my own state, they're interested in GME. We've talked about GME, but we still haven't heard anything. So again, if you're in the camp that I'm in where you haven't heard anything, you're not alone. I think that, Emily shared this earlier, but a lot of us are still waiting to hear what's officially going to be funded and supported.
And then we did get a question for contact information. So we put both our team inbox as well as our individual email addresses. And then we did get a question, I'm gonna let Lori take this, of what's next in this work? What is the next phase of this great work?
Yeah.
Thank you for that great
Oh,
question.
great question. So we're excited to launch State GME. We'll be adding some tools and resources, our table with all of the great examples that you can learn from. One thing that we'd love to do is create like a State GME toolbox where tools can be shared for folks doing State GME work. Another thing that we're looking at is a State GME peer learning network, but we really want to keep that focused to folks who are actually on the ground doing State GME work. There's a lot of interest in this, but we want, again, that peer learning network to be those folks actually like implementing state workforce in their state. So again, that's something that we may have like an application process or, just some validation to make sure we have the right people at the table. But again, we're really excited about this. I think that, it's an area of great opportunity as we look at some of the barriers and constraints that we see at the federal level, just with, lack of movement in GME, opportunities to grow caps, et cetera. State work is where you can really see, I think, the highest return on investment at this point.
Yeah, the other thing we're going to be looking at is the impact of the Medicaid GME specifically. It's hard to quantify, but I think it's important to really try to quantify some of the way that Medicaid GME is supporting rural and underserved GME, which we know is happening kind of across different states. So that's one thing that we're doing next. And then from a research standpoint, we're also looking at kind of what are the filled positions across different states and how does that look per population? We've had a lot of shift in population, but not much change in the distribution of GME. And so trying to create tools that can help guide you guys and really be just a tool that you can bring to conversations with policymakers and data where we have data, we want it to be used and kind of available to you. So we're also updating our hospital lookup tool. It should be newly updated and put in our rural GME portal, hopefully in the next 2 weeks. And we've recently updated our hospital analyzer. All those things are things to really give you data and resources for your engagement in growing GME.
I want to just do one final plug for our annual meeting. I know we talked about it, but I know we talked a lot about rural health transformation. And Kate Sapra, who is in charge of Rural Health Transformation Fund at CMS, is coming to our annual meeting. We'll be presenting. So again, I think that, even if your state doesn't have anything specific for GME, like Emily said, there could be potential in year 2 or year 3, or in kind of that vague workforce category that you could potentially link GME into that. So again, if you want to, really, hear what's happening, our annual meeting is probably the best place to do.
And we are coming to time. There is a question if Emily or Laura, you can kind of address it in a minute about ways that a medical school can build partnerships for UME GME pipeline that isn't part of an academic health system. Many times it is seen as taking up residency learning opportunities.
Yeah, that's a great question. And I think, it really, starts with just building relationships and even just looking at, the value that you all bring, to the conversation. And when I think about osteopathic medical schools, we're not blessed to have one in our state. But I think, when I'm talking to hospitals, especially rural hospitals, they may have partners, but the partners may not be mission aligned, right? They may not have graduates who are going into primary care. They need primary care doctors. So, really kind of just looking at it more like, could they be like Switzerland? Like you could work with more than one medical school, and taking medical student rotations, or, if they are, even linked with a GME program, you don't have to just work with one GME program. You can work with a couple of different programs, right? It's really about what's best for the state. And I'll end with one example. We've actually got a hospital up in northern Wisconsin. They're a critical access hospital. They're absolutely wonderful. They actually host residents from two different psychiatry programs. They have an inpatient psychiatry unit. They just started hosting residents from a different health system who have an internal medicine primary care track. And again, it's just neat to see kind of these cross, institution partnerships, and they're creating their own family medicine residency. So I think that that's just one example of, when you kind of build that partnership, like, we're not looking to displace anyone. We're just looking to enhance and to add on to what you're already doing, that can sometimes be really well received. So that would be probably my advice in a minute.
Thank you so much. So I think we'll wrap up and just thank Emily, Lori for sharing your expertise, the various examples and cases that you presented, and just the practical insights with us today. We appreciate everyone for joining, for your engagement throughout the webinar. As a reminder, the recording and related resources will be posted on the AOGME webinars webpage. And if you have any follow-up questions, again, the email address were posted, but you can also email us at aogme@econ.org. Thank you, everyone. We hope you have a wonderful rest of your day. Bye-bye.
Thanks, Alenta.